My name is Yannick van Lochem. I'm an aesthetic physician. I was inspired actually by my grandparents. I remember their stories that they traveled the world to teach about their new specialty called immunology. They actually set the foundations for this new medical specialty in their time. And they inspired me to actually go to and stay in medical school and become a doctor myself. I remember when I started to discover aesthetics, it was because my former girlfriend at the time, she discovered it. And she said, Yanni, you have to come and look at this new amazing thing that I've discovered. It really suits you. And at that time, I was still in medical school, and I said, well, you know, I'm not going to abuse my medical title for something as superficial as making healthy people more beautiful. But, you know, because she proposed it to me, I went along with her and I saw the magic of the art of injectables. How there was a nice balance between being artistic, but also being scientific, with knowledge of anatomy, knowledge of products, but also the techniques were incredible. And I realized that helping people is what a doctor actually wants, could also be achieved with the people that want to improve their beauty. And along the way, I've been part of some incredible things, like aesthetic medicine becoming the world's first 2-year medical specialty. And that's a truly amazing thing, because we are now an established medical specialty with a protected title as the first country in the world. My ideal in beauty, I wouldn't say that it fits into a certain concept. What I wish for in my patients is that they are not limited to what people think or what society thinks, but they can just be themselves, their real selves. And that is using their own personality, using their own aesthetics that they already have, and just tweak that in a tiny little way in order to just make them radiate without them looking like they've been injected. I always say, I want the people to notice my patient, not my work. And I think if you try to change people into something they're not, then you're not in the right game. So what I try to do is I look at my patients, I see the beauty in my patients, and I amplify that beauty. And so it really depends on who I have in front of me, and that determines what I'm gonna do. And definitely there are some background, some theoretical and scientific background that I use, like, for example, the golden ratio and like symmetry. And of course, I see the age-related anatomical changes, because I know that youthfulness is also considered to be beautiful. And I look at sex-dependent characteristics in the face. So with a female, I enhance the feminine sides of them, and with males, I enhance the male characteristics in their faces. But overall, I wouldn't say it fits into a specific concept. I just look at my patients and bring out the beauty that they already have. So today, I will be showing a treatment with a beautiful young woman. She's 28 years old and she looks already amazing. And that is a challenging patient, because if she is already that beautiful, there's a lot you could do wrong. So it's really important that we give her a very, very thorough facial assessment. And that means that we have to really look in detail to what we can enhance and what we have to hide. So in this case, we will see that I'm going to look at the entire face and find all these little places where I will relax some muscles, or I will place a little bit of volume, just strategically, in order to just bring out the most beautiful version of herself. And so I will enhance her feminine traits, and I will, let's say, hide the more masculine traits to make her face a bit softer, a bit more open, a little bit more elegant, and overall a bit more attractive. And so with this pan-facial approach, there is going to be a few areas that are especially high-risk zones. And of course, The aesthetics part is very straightforward. It means looking very well at the patient to see where she needs the products. And then with the treatment, it's really important to make the treatment as safe as possible. Right? She is beautiful already. It would be devastating if we would cause any kind of complication for her. And therefore, we have to be very smart in avoiding complications. So during the treatment, I will show treatment techniques with specific products that have a low risk of complications. I will use specific instruments, which will be the safest instruments of choice. For example, when I'm going to treat the forehead or the nose, I will use a 22 gauge cannula, because that gauge cannula is the least likely to enter into a blood vessel. And of course, you may know that the forehead and the nose, aside the glabella, have the highest risk of visual loss after filler injection. So there we have to take many precautionary measures into consideration. Amongst them is the cannula size choice, but also the amount of product that you inject per bolus or per retrograde. If you think about blindness, the risk of blindness, we have to minimize that as much as we can. And taking the science into consideration, we know that if you would inject a filler into the supratrochlear artery over here, then you need a certain amount of filler to actually reach the retina. And that amount is somewhere between 0.04 and 0.12. according to the cadaver dissection. So with a safety margin, I have decided not to inject more than 0.025 per retrograde or per bolus. So that means if you want to fill the forehead, you have to inject a lot of retrograde linear threads. So that means take your time, be gentle, don't force the cannula through any structures that shouldn't be forced through. Let's take the forehead, for example. You go through the galea. That needs a little bit of resistance. So you pop through the resistance, but after that, you have to use the cannula in a very gentle way, which means take the cannula between 2 or 3 fingers, roll it. It's like the English drink their cup of tea, right? It's the tea time technique. You roll it while you pulse it back and forth. Then when there's some resistance, you will actually guide the cannula past that resistance, and without putting any force behind your hand, you'll actually be able to get that cannula where you want it to be. And of course, we also have to think about the safest anatomical layer. In the forehead is the periosteal layer as long as you're above the inferior frontal septum. These recommendations are included in the article that I've published with my colleagues in PMFA Journal. And these are the 10 recommendations to minimize the risk of vascular complications. And apart from these high-risk zones, of course, I will also cover lower risk zones, temples, cheeks, tear trough, and I'll use different products. So I'll go from the upper third to the middle third to the lower third of the face, so the jawline, chin, lips. It's basically a pan-facial approach, a global facial approach, with multiple products, with hyaluronic acid, with radius, and with botulinum toxin. And so it's going to be definitely worthwhile having a look. So I wish you a lot of fun looking at this video. Today we are going to be looking at a young, beautiful woman. And actually, she didn't really have a very specific question for me. So our challenge is to find those little places that we can give her some product, tiny amounts, so that we don't change her, but we just amplify the beauty that she already has. Therefore, we have to give her a very good facial analysis. And then based on the plan where we want to place some products, we have to find the safest ways, the safest anatomical layers, the safest instruments, and the safest products in order to enhance the beauty that she already has. So let's have a look and analyze her face together in the upper, middle, and lower third. Okay, so let's start with the general impression. Now, looking at her face, you can see that maybe one of the things that jumps to your attention is that her brows seem a bit low for a girl. And it would be nice maybe to raise her brows a little bit. Can you raise your brows for us? Yeah, so there's still some force in the frontalis muscle, so we could probably inject the depressors with some botulinum toxin. You close your eyes very forcefully. Yeah, as you can see, there is a little bit of force in the depressors, and relax. So they have been relaxed already, probably because of the same reason. To raise the medial brow, we just have to inject some botulinum toxin in the depressor muscles, and therefore that will raise the position of the medial brow. For the lateral brow, the same thing. We can inject some botulinum toxin, but it would be very nice if we can combine that with a little bit of hyaluronic acid that we will inject in the temporal hollow. Then let's have a look at the filler indications. So looking at her forehead, you can see that if you look at the light reflection, it looks pretty good, although you may already see a little reduction in light reflection just in the central forehead. If you look at the forehead from the side, it's also visible that she has a tiny flattening or even a concavity in the central forehead. So that for us is a very, very amazing place to place some filler, some hyaluronic acid. And in her case, it will probably be Bilatero Balance that I'll be injecting with a 22 gauge Steriglide cannula. And of course, this is one of the highest risk areas in the face, the forehead. So we have to take very, very specific precautionary measures to avoid complications. We have prepped our patient, and so she's been disinfected, and she's removed her jewelry, her earrings, and she's got a band in her hair to make sure that we have a very low risk of infection. So I'm going to inject the fillers first because I will be massaging the product after injection. And if you would inject the toxin first, then of course with the massage you could move the toxin to a different muscle that you don't mean to treat. So therefore, fillers first, and then toxin if you do it in the same treatment. Right, let's go and look at the frontal concavity. So I'm looking at her forehead from different angles to determine exactly where that flattening, where that concavity is. And I'm putting some markings on her forehead, and they're about here. And so that will be the area, so like an oval over here, where I will be injecting some Bilatero Balance in the subgaleal space. What I'll do is I'll start just above the concavity. I'll give her an entry point in the midline, and I will be using a cannula, non-traumatic cannula. And so my cannula will be going in this direction in a fan-shaped pattern. Because this is a very high-risk area, we have to think about the different risk areas. Now, if I compress the skin like this between my fingers, I see that over here and over here, there is a crease, so the glabellar crease. And that is, of course, the possible trajectory of the supratrochlear artery. Now, as you can see, that entry point is right there in that crease, so I probably would be wise to move it a little bit more into the area between those two creases to avoid bruising. And these arteries are located first in the lower part of the forehead. They can be located in any anatomical layer, but above there's an inferior frontal septum. Can you raise your brows? So over here is probably the inferior frontal septum. So, and relax. Below this line is the highest risk area, because there the arteries could also be on the periosteal layer. Above that line, the arteries, the supratrochlear arteries, are in all anatomical layers are possible, so layer 2 and 3, but layer 4 and layer 5, which is periosteum, they're not present anymore. So if I'm going to be injecting above this line, which is conveniently inside the area of the frontal concavity, then of course I would be relatively safe when the cannula is on periosteum, because the arteries are in a more superficial anatomical layer. Now I'm going to give her a little bit of anesthesia just at the entry point, and I'm injecting some lidocaine with adrenaline, but also I want to inject some local anesthesia at the supratrochlear nerve. So again, I'm just going to see where that crease is, and over there I will take my needle and go straight to periosteum, very soft touch, and inject a small amount, 0.1,
on one side and very soft touch to periosteum, 0.1 on the other side. So very tiny amounts because I don't want to distort the aesthetic situation of that area too much. So the second nerve I want to anesthetize is this supraorbital nerve, and I can palpate the supraorbital rim. I feel the notch over here, so I know that over here is where the nerve is coming out of the orbit and going a bit laterally. There's a lateral branch over here. There's another lateral branch that's going down there, and it kind of like goes with different branches up and innervates the scalp. So with my index finger of my non-dominant hand, I feel for that little notch. I go in with that invisible needle and I start to inject about 0.1 ml of lidocaine with adrenaline. And I flatten that little bump that I've created and try to push that anesthesia towards that supraorbital nerve. All right, so now I'll move to the other side to treat the other side. And so again, with my non-dominant finger, I just palpate on the supraorbital rim. I feel that supraorbital notch over here. And I go in and I inject 0.1. And I feel that liquid coming out of the syringe pressing against the tip of my finger, so I know the product, the lidocaine, is ending up in the correct place. So now it should be relatively painless if I will be injecting inner frontal concavity. So I'll start with the pre-hole, and I'll use a 21 gauge needle for that. That's supplied with the TSK Steriglide cannulas, the 22 gauge, because I'll be using one of those. I'll be using a 22 gauge 50 millimeter TSK Steriglide cannula. The reason for that is that this cannula is thick enough to be safer than the 25 gauge. It's nice and rigid, so it's very easy to control the cannula because it's very important that we make sure that's in the correct layer. So it must be on periosteal layer, which is the same as a subgaleal space in the forehead. And the 22 gauge will allow me to actually feel the resistances a bit easier. So I'll go in with the tip of the cannula, and first I go horizontally. So I lift up the tissue in front of the cannula and I push through the galea. I feel a click and then I'm through. And as you can see, when I move my cannula back and forth, it moves independently of the tissue very easily, so I feel that I'm below the galea. I'm not intramuscular. I put the bevel down. Here's an indicator of the bevel. I put it down because I want the product to be on periosteum. Now I'm going to close the supratrochlear arteries temporarily, and I'm going to be looking at the markings of the syringe and make sure that I inject 0.025 mLs per retrograde. And if there's a little bit of resistance, I lift up again, and then I want to advance the cannula while rotating, right? So when I'm rotating, I don't want to put any pressure. So I rotate and I kind of give a pulsing movement back and forth until I get to the area that I want to stop at. So that's right over here. I feel with my finger, I feel the tip of the cannula, and I close the supratrochlear arteries and I inject 0.025. Now I get to the area where I'm parallel to the arteries, and so this again forces me to be very careful to make sure that I never inject more than 0.025 ml per retrograde. So I'm looking at the markings of the syringe, and so there's at least 2 retrogrades per marking of 0.025. And so, as you can see, I just do very, very, very many, very tiny retrograde linear threads. And whenever there's some resistance, I can go back and click through the galea again, and small amounts. As you can see, I'm not putting any pressure. I just want to make sure that even though it's a very low risk of getting the cannula into a vessel, not putting any pressure behind it. Okay, so I'm almost done. And the last one. Okay, so now I'm just looking from the different sides to see the contour of the forehead, and I need a little bit of evening out to the lateral side over here. So I use a purposeful molding technique, which is called the rock and roll technique. I like that name because it's kind of like rocking the product and then rolling your finger. And that is a very nice purposeful molding technique. So it's not a general kind of evening out, but it's kind of like more of a pushing the product to a specific location. Now I've used Belotero Balance, and that's a very forgiving product for the forehead. It's very smooth, it evens out naturally. Other products may give you some irregularities, and in that case what you can advise to your patient is that in the evening, so not the whole day, just in the evenings after brushing your teeth, you can use your deodorant roller or maybe a bottle of some sorts and use that as a roller to put some pressure left and right to even out any irregularities, especially in the first 2 weeks when there is a little unevenness visible. So we're going to inject a tiny amount of volumizing hyaluronic acid in the temple. Well, as you can see, you can already see there's a little depression over here, so that could be our target area. And let me just check, because there is the temporal crest, there is the lateral orbital rim, and of course that is actually in the one up, one over area. So exactly in the, let's not call it safe spot, but low risk spot. Because if we want to put our needle on the periosteum over here, of course we have to know where our enemies are and what their names are. Most of the physicians know the superficial temporal artery. You can actually feel it pulsating. So I feel it over here, but over here I don't feel any pulsations. So there are two arteries that could be dangerous for us because we will be injecting on the bone, and that are the anterior and the posterior deep temporal artery. So it's two arteries that are running kind of vertically, and they are running very, very close to the periosteum. So when I put my needle in over here, I should assume that it could be intravascular, and therefore we have to use a smart preventative technique. This is Belotero Volume on a 30 gauge needle, and I'm going to advance the needle straight to periosteum. I feel the periosteum, so I give a soft touch. I don't aspirate because I can't rely on aspiration, but I'm looking at my plunger and I'm injecting 0.05 in one bolus. Then I retract, reorient, and readvance back to periosteum. Soft touch again, and again about 0.05. So I retract the needle, reorient, and readvance back to periosteum, soft touch, and again I inject a small amount of about 0.05. So I've injected 0.15 in total on this side. I definitely see a reduction of that little concavity, and you may see a slight elevation of the lateral brow, the tail of the brow. So I'm going to move to the other side as well. Here's the temporal crest over here, lateral orbital rim, and I'll be injecting in this little circle, 30 gauge needle, 1, 2, 3, soft touch to periosteum, small amount, 0.05, and retract, reorient, readvance, again soft touch to periosteum, 0.05, and then over here, 0.05, and I mold it. Normally I just pull and mold because I believe that pulling the brow and then molding the product aids in lifting the tail of the brow. So I'm going to mark her for the toxin injections. So there's one in procerus muscle, one in the medial head of the corrugator muscle, which is about in the medial canthal line, and one in the lateral insertion just above the brow, maybe just medial to the mid-pupillary line, and I'll do the same on the other side. Then I want to lift especially the tail of the brow, so I'll give her 3 or 4 injections over here. So that's gonna be responsible for lifting the lateral brow. So I'm gonna start with the procerus muscle, and I'm using a TSK invisible needle, and I'm injecting 4 units in the procerus. It's about 1/2 centimeter of depth. Same is on this side, so it's a deep injection because the origin of the corrugator muscle is deep on periosteum, and then the lateral corrugator is an insertion, so it's a superficial injection, and as you can see, I keep pressure with my non-dominant finger on the supraorbital foramen to prevent spread into the orbit. Same goes on the other side, left side. A relatively deep injection for the medial head of the corrugator, then a more superficial injection laterally in the tail of the corrugator, pressing up so that the spread of the toxin goes upward and not downward into the orbit. To lift the lateral tail of the brow, I inject into the orbicularis oculi muscle and over here. So these are all superficial injections. 2 units over here, 4 units over here, so it's quite a high dose. 4 units over here, and 2 units over here. So I use maximum force to push up to lift those tails of the eyebrows. Same goes in the other side. So at the peak of the brow, I give her 2 units, 4 units in the middle of the tail, 4 units at the tip of the tail, and then 2 more units just below. And that concludes the upper third of the face. If you take a very close look at her right versus her left side, you may notice that her left side is a little bit flatter and her right side has a bit more projection. The flatter side is usually the side that the patients sleep on. Do you sleep on your left side? Yeah. And usually the other side is the favorite side for the patients to be on a picture. So we have to inject a little bit more product on the right side than on the left side. And from there, from the cheek, we of course have to go to the infraorbital area. First the cheek, lateral cheek, medial cheek, lateral infraorbital area, medial infraorbital area. That's the order of things, because if you inject something on the lateral side of the cheek, it will affect the medial cheek. And if you inject something in the cheek, it will affect the infraorbital area. Also, injecting something into the lateral infraorbital area, the palpebromalar groove, will affect the tear trough. So that is a general order of things. She may benefit from a bit of tear trough injection. If you have a look at her lower lid, it looks like it could be a bit puffy in the morning. So we have to be careful with hygroscopic products like hyaluronic acid, especially the thicker ones that will attract more water. So in her case, we could either go to a very, very light HA, something like Bilateral Soft, or we could go to a product that does not attract any water, like Radiesse. And I usually use Radiesse in a standard dilution for the tear trough. And even though in some countries that may be off-label, there's a very effective and safe way to use that product in the tear trough. Now, another very important area of the mid-face is, of course, the nose. Now, I think her nose is already very nice and very straight, and I'm looking from the side, and her nasofrontal angle, which ideally is at the supraciliary line, so that is the lash line. If you would draw a line between the eyelashes, it would end up just above the current position of the nasofrontal angle. So we could raise the nasofrontal angle just a tiny little bit, and while we're at it, we could also do something about the light reflection on the dorsum of the nose. As you can see, there's a little bit of a depression in the nose tip. So we could make this it will probably cost us less than 0.1 ml, but looking at the tiny improvement that we could have on her nose, that would be beneficial for her, because it will be a subliminal improvement, very tiny improvement, but all these little improvements together will definitely show a general improvement and general
beautification of her face.
So we're going to move to the medial part of the face, so the middle third of the face, and starting with the cheek. I really love that vector line that she has here, so I'm going to use that vector line and keep it as it is. So this is going to be the lateral cheek. Of course, she may use a bit also in the medial cheek or the anterior cheek, and then the tear trough area as well. Now, this area I will be injecting with Belotero Volume, and I'm just going to target that apex of her cheek. So I'm going to go down from the lateral orbital rim, and I'm going to draw a line between her ala and her helix of her ear, and that will give me a very nice point of maximum projection. So I will use a tiny bit of local anesthesia for my entry points. One over here, 1, 2, 3. One over here, 1, 2, 3. And one over here, 1, 2, 3. So for the lateral medial cheek, I'll be using Belotero Volume. For the tear trough, I'll be using Radiesse. Okay, I'll give a little pre-hole with a 22 gauge or 23 gauge needle. And from there, I will enter with the 25 gauge, 5 millimeter cannula, 5 centimeter cannula, and go first through SMAS, click. So, and after this, no more force. Put my bevel down, go to that apex. I just palpate with my non-dominant finger where the tip of that cannula is, and it's exactly underneath this little circle over here. Now, I lift up the tissue and I give a little bolus, 0.05, a bit more, 0.1. And then after this, I do a retrograde of about 0.1 as well. So the second entry point is going to be here, 1, 2, 3. And that's going to be for the anterior cheek. And I go to the V-frame deformity, 1, 2, 3, click, and click. Now I'm on periosteum. Cannula is exactly over here. Let me check again. Just at the end of the tear trough, and I give a little bolus of about 0.05. And I'm looking at what I've done, and I think it's exactly enough. We have to be very, very minimal. She needs a bit more on the other side. So in total, I've injected only 0.2 in her right cheek. Now we go to the tear trough area, and I will be using Radiesse in this area because I want to prevent malar edema. And so from here, 1, 2, 3, I give her a pre-hole, and then with standard dilution of Radiesse, which is 0.3 ml of lidocaine mixed with 1.5 ml of classic Radiesse, and I've put it on a 25 gauge 38 millimeter Steriglide cannula. It's all TSK cannulas that I'm using because of their rigidity and their coating. They have a silicone coating and kind of a cone-shaped tip. So I feel periosteum now, and she says it's a bit painful. For me, that's a good sign because I know that I'm on the periosteal layer. As you can see, I'm not putting any force behind my cannula. I'm just rotating. I have it between like 2 fingers, maybe 3. Just like the way that the English drink their tea, 1 pinky in the air. Okay. So now I've injected 0.15, 0.15 mL of Radiesse in the tear trough. Now let's go to the left side. Okay, on this side I'll just use a bit more. So again, I'll draw a line between her upper ala to her helix, which is over here. Then I'll draw a line down from her lateral orbital rim. So about here, I'll give her a bit of product. And from here, I will give her a bit of product over here. And then the tear trough I will inject with Radiesse. Okay, 1, 2, 3. And 1, 2, 3. Okay, so I'll make a few pre-holes. 1, 2, and 3. Okay, I'll start with the Belotero Volume. have to go through SMAS first. So lift the cheek up, lift the tissue in front of the cannula. I feel the resistance, I click through. Then I'm on periosteum. On periosteum, it just slides. If I have any resistance, I just rotate and pulse. And I keep my finger in front of that little marking over here, of that apex. And I feel that the cannula tip is just lateral to that. And I start to inject 0.05, 0.1, 0.15, and a retrograde of about 0.1. Then for the anterior cheek, I go in the pre-hole and then lift, go through SMAS, and I end up on periosteum, just above the zygomatico-cutaneous ligament, and then I go through the zygomatico-cutaneous ligament, and just underneath it I inject another 0.05. So I injected just a little bit more on the left side than I did on the right side. And what I have to do now is inject some radius into the tear trough. So I enter into that pre-hole, so I rotate to go through the skin, then I lift the tissue in front of the cannula to go through every layer, click, and end up on the periosteum. Now I start injecting the product that contains some lidocaine that's mixed through it. And while sliding over periosteum, I give very small amounts, totaling about 0.15. Yeah. And maybe all the way to 0.2. 0.2 mLs of radius standard dilution on periosteum. So I'm gonna have a look at the nose. So what I wanna do is inject a small amount of product here at the nose tip. And I want to recreate a bit of sharpness on the nasal dorsum. And I want to create a bit higher nasofrontal angle. And I'm drawing this line because this is the midline of the nose, and I want to stay in that midline. Now, I know that the arteries, the dorsal nasal arteries, are more lateral to that midline and are in the subcutaneous layer most of the time. Of course, it's always possible that there are some branches who are also on the periosteal layer, and therefore we have to be extremely careful with the amount of product that we inject, especially because I'm also going to be injecting in the subcutaneous layer. And if I want to avoid blindness, I have to make sure that the amount of product that I inject is never going to be enough to reach the retina in case of intravascular injection. So I will use an entry point just below the nose tip. 1, 2, 3. A little drop of local anesthesia. And to optimize safety, I will be using a 22 gauge cannula. So in the midline, just here, I make a pre-hole. And with the 22, I will go into the opening. So now I'm subcutaneous. I want to go sub-SMAS, so I want to feel one click. And then, now I'm in the supraperiosteal space, I want to advance the cannula. Now I'm at the dorsal hump, periosteum. I want to go through procerus, 1, 2, 3, click, through procerus. And now I'm still on periosteal layer. So the layer 4. I have my bevel down, again I press and I inject 0.025, bilateral intense. Re-advance, 0.025. I move back, I give a tiny bit of product in the supra-tip angle, 0.025 is enough. And then at the nasal tip, I give a bolus of about 0.025. When I want to add more, I change position, and again 0.025. Now I'm in the subcutaneous layer, I re-advance the cannula. So now I'm in the territory of the dorsal nasal arteries. So that means I have to be gentle. And I stay in the midline, bevel up, because I want to create a little bit of light reflection exactly where you see the cannula's positioned right now. Press, looking at my scale, And I start to inject 0.025 in one retrograde linear thread. So I go back to the subcutaneous layer, which is the high-risk layer. I stay subcutaneous, I don't use any force. And bevel is up. Press through dorsal nasal arteries. Inject 0.025. Re-advance 0.025. Now, what I want to do is I want to raise a little bit the position of the nasal tip. So I go through SMAS, I lift the tip position, and I start to inject a little bolus. Again, all these boluses are only 0.025 mLs. And if I want to improve that effect even more, I go down the columella, click down the columella, and inject small amounts again.
You can see that she has quite a strong jawline. Can you bite your teeth? Yeah, and quite strong masseter muscles as well. Now this creates a beautiful definition of her jawline. However, it does look a little bit masculine if it's very strong muscular appearance. So a lot of times I would recommend reducing that muscle, although in the same time I would like to keep that beautiful definition of her jawline. And therefore what I usually do is I want to inject the masseter muscle to also give more of a change from projection of her cheek to a depression below the cheek. So there's more of a shadow line, more of a vector line in her face, and then reduce the masseter muscle to improve femininity, but inject some product along the jawline to give that jawline enhancement and make that definition of that jawline very, very strong. Which means that if you look at the change from the cheek to the neck, it should be a very dramatic, sharp shadow. So this shadow should be like light and shadow. So very quick change, so not so rounded, but very, very, very sharp shadow. Now looking at her from the side, you see that she may also benefit from a little bit of projection of her mentum. And that also, when you inject a little bit of inner chin, give her more projection, that can also help in creating the beautiful defined jawline. And it's especially nice to inject something in her chin if we also want to inject something in her lips. Now, I asked her just before if she would like to do something on her lips. And of course, like all the girls, she said yes. But I'm always very, very careful with lips because that is the #1 giveaway. If she doesn't want to look injected, then we have to be very careful with the amount of filler that we put in our lips. So I would definitely say, all right, we'll do it, but we'll do a tiny little bit. She's had it done before once, and she noticed, because she is a kind of person that attracts water when she's injected with hyaluronic acid, she noticed that even above her vermilion border, she saw a little bit of swelling. And that means that we have to be careful with selecting the specific product. So if we would select a product that attracts a lot of water, then we could give her that problem again. So in my case, because I use the Belotero range, I will use Belotero Balance for lip augmentation and not Belotero Intense, which is actually the standard choice. So we're gonna go to the lower third of the face, and I'm gonna start with the mandibular angle, and I'm going to start with the contour of the mandible. So I usually start at just behind the mandibular angle itself. So I palpate for the bone. So over here is the mandibular angle, so I just go a little bit behind it and a little bit more cranially. So from this entry point, I can go with my cannula, go up into the preauricular area, but also go along the mandibular border to just make that transition a bit sharper. Of course, we can also use a product like Radiesse for skin quality improvement. In her case, it's not really necessary. So I'll just be focusing especially on contouring. After that, we can inject some toxin into the masseter muscle. And the second entry point is at the pre-gel sulcus. So from here, we can continue that nice line along the mandibular border all the way here to the mentum. And then the Pogonian can be
injected with either Radiesse or Belotero Intense. Usually I use Belotero Intense for Pagonian. So I'll give her a little blab of local anesthesia right there at the entry point. Here we go. Only 0.1 is enough. And then at the pre-gel sulcus entry point, 1, 2, 3. Here we go, 1 is enough. Okay. Then I'll make a little pre-hole. 1, 2, 3. You shouldn't feel that anymore. And 1, 2, 3. So I'll use the same syringe of Radiesse that we used for the tear trough, which is a standard dilution of Radiesse. And I usually use a 25 gauge cannula for this area, 25 gauge, 50 millimeters. And I stay subcutaneous. The arteries over here are usually deep, and therefore I stay subcutaneous. It's a relatively safe area to inject. And so it's a slow retrograde linear thread of about 0.1, and then I can have another one just medial to it, 0.05. And then what I sometimes like to do is just create a tiny fan with short retrogrades over here, just to accentuate that angular appearance of the mandible. And then I go all the way to the post-gel sulcus. So I don't inject inside the gel. I stop at the post-gel sulcus and I inject a retrograde linear thread of about 0.1 to create a bit more dramatic shadow transition. So the medial entry point is the pre-gel sulcus entry point. Go into that opening and advance the cannula just subcutaneous along the mandibular border to the midline. And then again, retrograde linear thread, about 0.1 or 0.15. So do the same on the other side. So I'm palpating the mandibular angle, so it's over here. I go in just above and just behind it, so it's right there. It will be my entry point, and then maybe, yeah, so over here. And then so from here I can advance the cannula medially and cranially. And then my second entry point is going to be at the pre-gel sulcus, right there, and then go medially towards that midline point over there. Little blab of local anesthesia, 1, 2, 3, and 1, 2, 3. So I lift up the cheek, I go in with my 25-50 cannula and advance it subcutaneously to the preauricular area, 0.1 retrograde linear thread. Then just next to it, a smaller one, 0.05. And then a few tiny retrogrades to accentuate the angle. So make sure that the projection is not lateral, but actually dorsal. And then the last one is going to be just subcutaneous at the mandibular border. And I stop just lateral to the inferior jowl fat compartment. And then the second entry point is right there. Okay. And again, I'll inject about 0.1 in a retrograde linear thread. Okay. Now we're going to look at the masseter muscle. Can you bite? Yeah, so the masseter muscle is bite harder. Yeah, over here is our belly. So this is the real strong point, but actually we want to accentuate this depression. So we're going to go a little bit above that point, and then we're going to go down as well. And I will be injecting with Bogature Xeomin 4 units per 0.1 ml. I have 40 units in total, so 20 units per side. I have 4 injection points. The central one will get 10 units. 1, 2, 3. And I'll go in deep, and I'll give her 4 deep and 4 in the superficial compartment. 4 in the upper part of the masseter. 4 in the lateral and 4 in the medial. Now we'll move to the other side. Can you bite? Okay, so I feel strong belly of the muscle right there. Relax. So 1 above that, 1 over here, 1 lateral, 1 medial one. All right, so I'm gonna go into the belly of the muscle, 4 units deep, 4 units in the superficial compartment, 4 units in the upper part of the masseter is all deep, 4 units lateral, and 4 units medial. Okay, so for the chin, I will take the midline. This is the Pogonian, this is the point of maximum projection. And I'll enter just below the mentum and make my pre-hole over there. 1, 2, 3. Little drop of local anesthesia. Then my entry point, 1, 2, 3. And then I enter with the cannula. So I'll do a multi-layer technique. One is subcutaneous. And I go straight to the Pogonium and I just inject a little bolus of about 0.05. Just left to that 0.05 and just right to that, again 0.05. Then I move back, lift the mentalis muscle, and go underneath that muscle, in between the 2 bellies of the mentalis muscle, and 0.05. Put the cannula on a different position, just a little bit to the right, 0.05, and just a bit to the left, 0.05. So now we can inject a little bit into her lips. So I will give a little injection of local anesthesia for the pre-hole on both sides. So I will start with injecting some bilateral balance into the vermilion border. And for the vermilion border, I usually use, it's actually the only time I still use a 27 gauge cannula because it will keep that definition of the lip very nice and sharp. So I go in and I find that potential space. And I inject a tiny amount, even less than 0.05. But you can see that it gives a nice accentuation of the lip contour. I'll do the same on the other side. 1, 2, 3, a little bit of local anesthesia. Entry point. Bilateral balance on a 27 gauge cannula. Can you open your mouth a little bit? So I normally take the lip and pull on it in order to get into that vermilion border. Alrighty. Okay. So I am at the destination and I'm starting to inject a small amount, even less than 0.05. So I will change to 25. Now I will go to the vermilion, of course. So it's in the dry red lip. And I'm just very gentle with that cannula. It is a sensitive area, but she's being very, very amazing. She's a tough cookie. And as you can see, small amounts, about 0.1. Can you open your mouth a bit? And then I roll between my fingers, and that's it. Even it out. Okay, so now I move to the lower lip. Pull. So very gently advance the cannula I didn't give her a nerve block, so yeah, I have to be very, very gentle with her because lips can be sensitive. All right. And then I press and even it out. We're almost done. So I'll go and find that pre-hole again. Can you open your mouth again? So I'll just give her a tiny amount of filler in the vermilion. The body of the lip. Just about 0.1. And then I'll give her a little bit in her lower lip as well. About 0.1. Now, as you can see, this mouth corner is a bit higher than that side, so I just have a little drop left and inject that here just below the commissure, right there. Now, we've treated a lot of different indications, and I think my patient is really done with me. But I think she'll like me again later. So after watching this video, you may be interested in reading the article on how to prevent vascular complications and how to treat vascular complications. These articles are both downloadable on the website of the pfmajournal.com. The instruments that I've been using in this video are the TSK cannulas and the TSK needles. If you want to know more about the TSK products, you can visit their website, which is tsklab.com. Lastly, we have created a specific course, Management of Vascular Complications and Retrobulbar Injections. And it's a cadaver course. It's in the Amsterdam University Medical Center. And it's a one-day course, plus the online theoretical background course. So there's a theoretical part, it's like a webinar style, and there's an online examination. And then there's the practical hands-on training. So during the hands-on training, we will be in the hospital with cadavers and also with silicone heads. And we will actually practice on how to react when you have an intravascular complication. And so it's going to be peripheral ischemia with impending necrosis after either hyaluronic acid or radius injection, and it's going to be retinal ischemia after either HA or calcium hydroxylapatite. And after the treatment of these severe complications with our cadavers, we still have some time to focus on prevention of these complications. So we will be able to actually practice the safest techniques of the forehead, of the nose, of the glabella, of the tear trough, the palpebromalar groove, the temples, whatever you think would be beneficial for you, we can practice also on these cadaver heads with a high focus on minimizing the risk of intravascular complications. So I welcome you to visit my website of UMA Institute. Go to UMA Academy and you can read everything about this course.